that is not being absorbed hangs around in the lumen of the GI tract, and it generally disrupts the normal formation of stool. Other symptoms that commonly occur in malabsorption syndromes include weight loss and also vitamin and mineral deficiencies. You should be familiar with the characteristic clinical manifestations that go along with malabsorption of certain types of nutrients. And let's start by talking about malabsorption of fat. When you cannot absorb fat properly from the intestines, you develop steatorrhea, which literally means fat in the stool. Steatorrhea can be pale if bile is absent. You need bile in order to absorb fats. So if you do not have bile flowing, and that's the cause of fat malabsorption, you will not have bilirubin in the stool, and bilirubin is what turns your stool dark brown. So if bile is absent, this will result in pale stools, which are often seen in fat malabsorption from problems with bile. In addition, fat malabsorption leads to voluminous stool. The fat tends to take up a lot of volume and make large volume of stools. Stools will float in fat malabsorption. That's because fat is not soluble in water, so the stool will separate from the water in the toilet bowl and the stools will float. And then finally, fat leads to greasy, foul-smelling stools, and you can also lose fat-soluble vitamins in the stool. Carbohydrate malabsorption, on the other hand, produces a watery diarrhea. This is because when you are unable to absorb sugar molecules, they produce an osmotic effect. They draw water into the lumen of the GI tract and create a watery diarrhea. And then finally, if you are unable to absorb proteins, the problem is not so much a change in the characteristics of your stool, but the problem is that you do not absorb sufficient amino acids in order to synthesize albumin. As a result, you will have low albumin levels in the serum, and this will lead to edema. The workup of patients with diarrhea is a topic unto itself, but I'll briefly review some concepts here that can be helpful to you in your Step 1 exam. When faced with a patient with diarrhea, it's helpful to decide whether the diarrhea is a steatorrhea, an inflammatory diarrhea, or a watery diarrhea. Steatorrhea, as I said before, results in greasy, foul-smelling stools and stools that float from a high fat content. Inflammatory diarrhea has red blood cells and white blood cells present, which you can see on stool microscopy. This happens with certain types of infection and also in inflammatory bowel disease. Watery diarrhea, on the other hand, can happen for one of two reasons. The first reason is called a secretory diarrhea. The classic example of this is an infection with cholera. Cholera secretes a toxin that stimulates the GI tract to secrete fluid and electrolytes. As a result, there is a watery diarrhea. On the other hand, you can also get watery diarrhea from an osmotic cause. So the classic osmotic cause is lactose intolerance, which we'll talk about later in this module. Patients with lactose intolerance have lactose molecules that stay in the GI tract lumen because they cannot be absorbed. As a result, this draws fluid into the lumen and causes a watery diarrhea. Because watery diarrhea can be due to an osmotic cause or a secretory cause, there is a test that is sometimes used to differentiate between secretory and osmotic diarrheas, and that test is called the stool osmotic gap. To calculate the stool osmotic gap, you need to send a sample of stool to the laboratory and ask them to measure the sodium and potassium concentrations in the stool. You can then calculate the stool osmotic gap by taking 290 and subtracting 2 times the sodium concentration plus 2 times the potassium concentration in the stool sample. If the patient has an osmotic diarrhea, the osmotic gap will be high, usually greater than 50. If the patient has a secretory cause of diarrhea, the osmotic gap will be low, usually less than 50. The easiest way to understand this is to imagine the lumen of the GI tract and imagine that there is some osmole present in the lumen of the GI tract which is drawing water into the GI lumen. When the water is drawn in, it will dilute the concentration of sodium and potassium, making the sodium and potassium concentration in the stool very low. And since the osmotic gap is 290 minus 2 plus the sodium plus 2 plus the potassium concentration, this number will become very large in an osmotic diarrhea. On the other hand, in a secretory cause, what you have is something causing water to be secreted into the GI tract, and with that water goes sodium and potassium. Therefore, the sodium and potassium concentration in the GI lumen will be relatively high, and that will create a small number for the osmotic gap. Now let's talk about specific causes of malabsorption, and I'll begin with a disorder that is relatively common and one that you are very likely to see clinically, and that is celiac sprue, which is also sometimes called celiac disease or gluten sensitivity. This is an autoimmune condition that results in destruction of small intestinal villi. We'll see some pictures of this in a minute. And it's triggered by exposure to gluten, which you may know is found in many forms of bread. Let's talk about gluten in more detail because it's very important to the pathophysiology of celiac sprue. There are two proteins found in wheat named gliadin and glutenin, and when they are combined together, they form gluten. And this is what happens when you bake bread with water. I've shown this on the screen to help you remember it. Gliadin is a protein, so is glutenin. They are combined when you bake bread and they form the structure of gluten. It turns out that the gliadin protein is the pathogenic component of gluten responsible for celiac sprue. And in order to be pathogenic, the gliadin protein has to undergo a reaction called deamidation. The protein molecule must be deamidated, and the enzyme that does this is called tissue transglutaminase. I've shown this reaction on the screen here to help you remember it. On the left side of the screen is a depiction of the protein gliadin. And found within this protein are glutamine residues, as I've shown on the screen. Tissue transglutaminase removes the NH2 group, that's called the deamidation reaction, and converts it to a COOH group. And it is gliadin in this form, the deamidated form of gliadin, that is immunogenic and triggers celiac sprue. What happens is the deamidated gliadin is consumed by antigen-presenting cells and presented to T cells. Celiac sprue is a T cell-mediated disorder. It's an example of a type 4 hypersensitivity reaction with T cell-mediated tissue damage. Now, what can be confusing is there are antibodies present in celiac sprue. We'll see in a few slides how they are useful for diagnosis. However, it's unknown how the antibodies contribute to the disease, and overall the disease is an example of a type 4 hypersensitivity reaction. And importantly, it's associated with several HLA antigens. DQ2 and DQ8 have both been tied to celiac sprue. Celiac sprue targets the small intestine. The duodenum is the most commonly involved portion of the intestines, and it's high yield to know the classic histology changes that you will see on biopsies of patients with celiac sprue. So the first classic change is blunting of the villi. If you look at the bottom left side of the screen here, this is a normal mucosal layer from the small intestine. You can see that these villi stick way out into the lumen of the small intestine. They are very long, and this is the normal appearance of villi in the small intestine. If you look over at the right, this is a biopsy from a patient with sprue, and you can see that the villi are blunted. They're much shorter than you would normally expect to see in the small intestine. A second characteristic finding is called crypt hyperplasia. These are the crypts of the small intestine. They are hyperplastic compared to normal. And then finally, you can find lots of lymphocytes in the lamina propria layer here of the small intestine in patients who have celiac sprue. Celiac sprue is common in whites of Northern European descent, and if you're not good at geography and you've forgotten which countries are part of Northern Europe, I'll point them out to you on this map. So Iceland obviously is part of Northern Europe, so is Great Britain, so are all the Scandinavian countries like Norway and Sweden and Finland. The reality is that many whites of Northern European descent live throughout Europe and even in the United States, so commonly you will see sprue in white people in general. There are several antibodies that are produced in celiac sprue which are very useful for making a diagnosis of the condition. Now, like I told you before, sprue is a T cell mediated disease, but there are antibodies produced, although their role in the pathogenesis is unclear. The first antibody is anti-gliadin, and this should make sense to you since I told you gliadin is the pathogenic component in sprue. This is rarely tested clinically, and that's because it's got a relatively poor accuracy for diagnosing the condition. The second antibody, which is used clinically, is anti-tissue transglutaminase, and I told you before that this enzyme is responsible for deamidating glutamine residues on gliadin, so that should make it easy for you to remember that antibodies to this enzyme are helpful in diagnosis of sprue. And then the third antibody is called anti-endomesial. The endomesium is smooth muscle connective tissue. It's not clear how this is involved in celiac sprue, but anti-endomesial antibodies do develop, and they are very useful for making a diagnosis of celiac disease. What's confusing about celiac sprue is that there are 3 antibodies that can be used to diagnose the condition, and in addition, for each antibody you can measure either the IgA level or the IgG level. This makes it very confusing to learn as a student, but I'll try to explain this on the next 2 slides. So IgA antibodies to the endomesium and IgA antibodies to tissue transglutaminase have the highest accuracy for diagnosis of celiac sprue. And IgA antibodies to tissue transglutaminase is an automated test, and this is often used for screening. You will send this antibody level, and if it is abnormal or increased, that will suggest a diagnosis. IgG testing is also done, and the reason for this is because some patients are IgA deficient. I talk about IgA deficiency in some of the immunology modules, but it is a relatively common condition, and patients who are IgA deficient will not make IgA antibodies to the endomesium and tissue transglutaminase. For those patients, you need to check the IgG level to these 2 structures here, the endomesium and the tissue transglutaminase. So a negative tissue transglutaminase IgA plus a low IgA level overall means the patient may be IgA deficient, and in this case you need to check the IgG antibodies. I've shown on the slide an algorithm that can be used clinically to make the diagnosis of celiac disease. You start by measuring the IgA anti-tissue transglutaminase level along with a total IgA level. If the patient has increased levels of IgA antibodies against tissue transglutaminase, that suggests they may have celiac disease. You can confirm the diagnosis with a duodenal biopsy. On the other hand, if they have negative tissue transglutaminase IgA, you then need to look to the total IgA level. If the total IgA level is low, this means they may be IgA deficient. In that case, you need to measure the IgG level of anti-tissue transglutaminase antibodies, and if that's positive, you can then do a biopsy to confirm the diagnosis. On the other hand, if they have a negative IgA against tissue transglutaminase and a normal IgA level, then that suggests that they do not have the disease. Unfortunately, this algorithm isn't perfect. There's sometimes disagreement, and this is something that's difficult to deal with clinically. But the point here for step 1 is that at the top right of the screen, I've written the 3 key tests for diagnosis of celiac disease. You measure IgA and IgG anti-tissue transglutaminase antibody levels. You measure a total IgA level, and then of course you can do a small bowel biopsy. To understand the symptoms of celiac disease, the most important thing to remember is that the duodenum is the most commonly affected portion of the small bowel. Any part of the small intestine can be affected, but the duodenum is most common, and this should make sense to you. You know that this disorder is triggered by exposure to gluten, and when we consume gluten, the first part of our small intestine that encounters the gluten molecules is the duodenum, so it's logical that this would be the most commonly affected area. And this is in contrast to tropical sprue, which we'll talk about in a minute. Tropical sprue tends to affect the entire small bowel. It much more commonly affects the jejunum and ileum, and that leads to some different symptoms. So patients who have celiac disease will develop malabsorption from involvement of their duodenum. They will have symptoms of flatulence and bloating. This is very common, as is chronic diarrhea. And the diarrhea is a steatorrhea because, as you know, fats are absorbed in the duodenum. So these patients have fat malabsorption and foul-smelling stools that float, like we talked about before. In children, this can sometimes present as failure to thrive. They will be eating poorly and not growing well. And then finally, recall that iron is absorbed in the duodenum, so you can potentially develop an iron deficiency anemia when you have celiac disease. The treatment is to eat a gluten-free diet and avoid wheat, and this is very difficult to do. There is bread and wheat in many, many things that we eat. Many packaged foods also contain gluten. So one of the difficulties for patients with celiac disease is finding a diet that they can tolerate. There is a small increased risk of small bowel malignancy among patients with celiac disease, and small bowel cancer is a very rare condition. We talk a lot about colon cancer and gastric cancer, but you will very rarely meet a patient who has a history of small bowel cancer. One of the conditions that can lead to small bowel cancer is celiac disease. There is an increased risk of adenocarcinoma of the small intestine. There's also an increased risk of a rare cancer called T-cell lymphoma. This is referred to as enteropathy-associated T-cell lymphoma, or EATL. And this is easy to remember because you know that T cells are involved in the pathogenesis of celiac disease. So if you know that, then you can remember that T-cell lymphoma is possible. And the classic scenario for a celiac disease patient who develops small bowel cancer is for the patient to report that they are very adherent to their gluten-free diet, but their symptoms are getting worse despite that. That is a patient who may have developed a cancer. Another condition that's associated with celiac disease is a skin condition called dermatitis herpetiformis. This is associated with celiac disease and it results in herpes-like lesions on the skin. That's why it's called herpetiformis. This is a picture of dermatitis herpetiformis shown on the screen here. These are very similar skin lesions. They are vesicular, just like what you can see in herpes. And it's caused by IgA deposition in the dermal papillae. The reason for this is not entirely clear, but it's very high yield to remember that it's IgA deposition in the dermal papilla that lead to dermatitis herpetiformis. This will resolve when the patient adheres to a gluten-free diet. Here's a picture of the layers of the skin just to remind you what the dermal papillae are. In the dermis layer of the skin, there are these little bumps, which are the dermal papillae, and each bump gets inflamed in patients who have dermatitis herpetiformis. Because the bump gets inflamed, the overlying skin becomes abnormal, and that results in the formation of the vesicles that you see in patients who have dermatitis herpetiformis associated with celiac sprue. Now let's talk about the other form of sprue besides celiac disease, and that is tropical sprue. This is a malabsorption syndrome due to an unknown infectious agent. It's believed to be related to an infectious agent because it responds to antibiotics, although no bacteria has ever been identified. It occurs in the tropics, that's how it gets its name, especially in the Caribbean, and it is similar to celiac sprue with blunting of the villi and many of the other histologic features. The key distinction between celiac sprue and tropical sprue, especially for step 1 of the boards, is the intestinal location of the two diseases. Celiac disease is most common in the duodenum, although it can affect the jejunum and ileum, but the duodenum is the most common location. Many people say that celiac disease affects the proximal small bowel. Tropical sprue, on the other hand, tends to affect the entire small bowel, including the jejunum and the ileum. This means that tropical sprue is often associated with folate and B12 deficiencies because, as you may know, folate and B12 are absorbed in the jejunum and the ileum. Tropical sprue often presents with steatorrhea from fat malabsorption. In addition, patients can develop a watery diarrhea from sugar malabsorption. So the typical case is a traveler who has been to the tropics, especially the Caribbean, and then develops chronic diarrhea and symptoms of malabsorption. All the antibody tests we talked about for celiac disease will be negative, and if a biopsy is done of the small intestine, it may show blunting of the villi. The treatment is antibiotics. It usually responds to tetracycline, and it's very important to supplement folate. As I told you before, tropical sprue can cause folate and B12 deficiencies. Now, it takes many years to become deficient in vitamin B12 because it's stored in the liver, but you can become deficient in folate more quickly, and this often causes a megaloblastic anemia, so supplementation with folate is an important part of treating tropical sprue. Whipple's disease is an infection with the bacteria Trophirma whippeli. It's a gram-positive rod related to the bacteria Actinomyces, and it's really a systemic infection. It involves the small intestine, and there are important components of malabsorption, but it also involves the joints, the brain, and the heart. It's most common among white European males, and this demographic suggests there may be an underlying genetic predisposition and a reason why certain populations develop it rather than others. 86% of patients are men, and the average age of onset is 49 years. This disorder was originally described in the early 1900s by a pathologist named Whipple. That's where it gets its name. And he described 4 cardinal features of the disorder. Those features were diarrhea, abdominal pain, weight loss, and joint pains. The diarrhea can be due to malabsorption of fats or sugars. Anywhere in the small intestine can be affected. The joint pains are classically migratory from one joint to another, and they typically involve the large joints like the hips or the knees. Other signs and symptoms you may see: the mesenteric lymph nodes can become very enlarged. This can sometimes cause abdominal pain and abdominal distension. There is a darkening of the skin, which is called hyperpigmentation. It happens to about half of patients. The central nervous system can be involved. This often presents as confusion and cognitive dysfunction. And then finally, some patients with Whipple's disease develop signs and symptoms of endocarditis. This is a culture-negative cause of endocarditis, which means that the blood cultures will be negative even though the patient has signs and symptoms of endocarditis. And the reason the blood cultures are negative is because Trophirma is a difficult bacteria to grow. You can make the diagnosis by doing a biopsy of the small intestine, and there is a classic finding that you need to know for step 1, and that is the presence of PAS stain positive foamy macrophages seen in the lamina propria of the small intestine. On the bottom left side of the screen here is a biopsy of the small intestine stained with the PAS stain. You can see that the villi are turning dark red or dark pink, and that's because of the presence of foamy macrophages. These are macrophages filled with Trophirma whippeli, and they stain positive with the PAS stain. Whipple's disease was fatal before the antibiotic era when it was first described in the early 1900s. Now it's usually treated with antibiotics. It responds well generally to ceftriaxone, and there are different treatment regimens that are used when patients have extraintestinal involvement, like of the central nervous system or the heart. Moving on, let's talk about lactose intolerance. So lactose is a disaccharide, which means it is made up of 2 monosaccharides. Specifically, it is a molecule of galactose linked to a molecule of glucose. This is its structure at the bottom right side of the screen here. Its formal name is galactosyl beta-1,4-glucose, which can help remind you that it contains galactose and glucose. Now, lactose can't be absorbed directly by the intestine, so there is a brush border enzyme called lactase, which is an example of an enzyme class called a disaccharidase that breaks down disaccharides. And lactase breaks down lactose into galactose and glucose. Basically, it splits the molecule in half, and then the molecule of glucose and the molecule of galactose can be absorbed separately. People who have lactose intolerance have dysfunction or absence of the enzyme lactase. As a result, the lactose molecules remain in the small bowel, where they exert an osmotic effect and draw water into the lumen of the GI tract. This creates a watery diarrhea. As we discussed earlier in this module, it will be a high-volume watery diarrhea. Importantly, the small intestine histology will be normal. The villi are normal. There are no problems there. The issue lies entirely with this enzyme found in the intestinal villi, which is not working properly. The most common cause of lactose intolerance is called lactase non-persistence. We're all born with functioning lactase in our small intestines, but the enzyme levels fall with aging, and sometimes they fall so low that the patient becomes lactose intolerant, and this is called lactase non-persistence. The frequency of non-persistence varies among different populations. The lowest prevalence is among European Americans. It's still relatively high, about 25%. The highest prevalence is among African Americans, Native Americans, and Asians. In some demographics, the frequency of lactase non-persistence and lactose intolerance is as high as 90%. You can also be born with a congenital deficiency of the lactase enzyme. This is relatively rare. And then you can also become lactose intolerant due to a secondary deficiency of the enzyme lactase. This happens anytime there is a mucosal injury in the small intestine. For example, if you have bacterial overgrowth or a viral infection or giardiasis or celiac disease or inflammatory bowel disease or any other cause of injury to the mucosa of the small intestine, this can cause you to lose your functioning lactase enzyme. And it turns out that the lactase enzyme is usually one of the first disaccharidase enzymes that is lost, and this is because it's found in a distal location on the villi. So if this is one of the small intestinal villi, it turns out that lactase localizes to the distal tip. This makes it very vulnerable if there's mucosal damage. Anything that damages the mucosa of the small intestine can cause this tip to be lost, and then the patient will become secondarily lactose intolerant. And this will present as lactose intolerant symptoms following some type of GI illness, potentially one of these that I've listed here on the screen. The symptoms occur only when people consume lactose, and as you may know, lactose is mostly found in milk and other dairy products like ice cream. People who are lactose intolerant who consume any of these products will develop bloating, abdominal pain, and a watery diarrhea. The diagnosis of lactose intolerance is often clear from the history. If the patient reports abdominal pain and diarrhea after consuming dairy products, that is sufficient to make the diagnosis. Sometimes when patients have abdominal pain and diarrhea of unclear cause, you can ask them to abstain from consuming dairy products for a week or two, and if their symptoms improve, you can also make the diagnosis of lactose intolerance. There are two clinical tests that are sometimes used. One is called the lactose breath hydrogen test. In this test, the patient ingests lactose. If they cannot digest it, bacteria in the small intestine will ferment the lactose into hydrogen. They will release hydrogen, and you can measure the exhaled hydrogen in the patient's breath, and if the exhaled hydrogen level is high, that suggests the patient is lactose intolerant. Another test that is rarely done in the modern era is called the lactose tolerance test. In this test, you monitor the blood glucose level after the patient consumes lactose. Remember that if they have the lactase enzyme functioning normally, lactose will be broken down into galactose and glucose, and this will cause the blood sugar level to rise. If they are lactose intolerant, there will be a tiny rise, usually less than 20 milligrams per deciliter of glucose, suggesting that they are unable to metabolize the lactose you gave them. Pancreatic insufficiency is another cause of malabsorption. This can happen to patients with long-standing cystic fibrosis or chronic pancreatitis or some obstruction to the flow of pancreatic enzymes. When there's insufficiency of the pancreas, patients lose pancreatic lipase and colipase and other enzymes necessary for the digestion of fats. This leads to fat malabsorption and symptoms of steatorrhea and deficiencies of fat-soluble vitamins. Bacterial overgrowth of the small intestine is another potential cause of malabsorption. Normally, the small intestine is nearly sterile. There are a very small number of organisms found, much fewer than are found in the colon. If significant bacteria grow in the small intestine, this can lead to excessive fermentation, which can produce gas. It can lead to inflammation, and it can lead to malabsorption. Bacterial overgrowth of the small intestine presents with bloating and flatulence and abdominal discomfort. These patients often have a chronic diarrhea. It can be watery due to malabsorption of sugars, or it can be steatorrhea from malabsorption of fats. This can also lead to vitamin deficiencies. Bacterial overgrowth can occur when there's altered motility of the small intestine. This can be seen in diabetes when there's enteric nerve damage from the blood sugar. This is also sometimes seen as a complication of scleroderma. You can also get bacterial overgrowth when there is partial or intermittent obstruction of the lumen of the small intestine. This can occur when there are adhesions from prior surgery or sometimes in patients with Crohn's disease. But in both cases, the principle is the same. Things are not moving normally through the small intestine, and as a result, those bacteria from the colon can creep backwards and start to grow inside the small intestine. The gold standard for diagnosis of bacterial overgrowth is to aspirate the jejunum and actually measure how many bacteria are present. This is rarely done. Another way to make the diagnosis is something called the lactulose test. I talk about lactulose in the module on GI pharmacology. It's a laxative. It's a sugar molecule that's not absorbed, so it works as an osmotic agent and draws fluid into the colon to stimulate a bowel movement. The reason you can use it to diagnose bacterial overgrowth is because the bacteria will metabolize some of it into hydrogen, and you can measure how much hydrogen the patient produces after administration of a dose of lactulose. If they produce too much hydrogen, it suggests that they have excessive bacteria present in their intestines, and the treatment is with antibiotics. I'll finish this module by mentioning some of the diagnostic tests that are occasionally used to work up diarrhea or malabsorption syndromes. The first one is called the fecal fat test. In this test, the patient collects their stool over 1 to 3 days. It's kind of gross and inconvenient, but when they return the stool sample, you can measure the amount of fat that is present, and normal is less than 7 grams per day. And you will see an increased amount of fat in the stool by the fecal fat test if there is some cause of fat malabsorption. This can be from loss of bile, like you see in liver or biliary diseases, because you need bile in order to absorb fats. This can occur with pancreatic insufficiency, like we talked about before, when you have loss of pancreatic enzymes. And it can also happen after some type of resection of the small bowel if you don't have enough small bowel remaining to properly absorb your fat. Another test that is sometimes done is called the D-xylose test. This is a test for carbohydrate absorption in the small intestine. After fasting, the patient ingests a dose of D-xylose, which is a monosaccharide. It is absorbed in the intestine, and there are no enzymes required to break this down into smaller structures. All the patient needs to have is a functioning mucosa. Later, you measure the amount of D-xylose present in the serum or in the urine. You should see a normal rise in the D-xylose level if the patient has an intact and functional mucosa. You will see abnormal results in things like small intestinal bacterial overgrowth or in Whipple's disease. In both of these disorders, there is something getting in the way of the mucosa absorbing the D-xylose. It is blocking the absorption of D-xylose, and therefore you do not see the normal rise. On the other hand, in disorders like lactose intolerance, you will have a normal D-xylose test result because the mucosa is perfectly intact and functional in lactose intolerance. The only problem is that they are missing an enzyme, but as I told you before, no enzymes are required for the absorption of D-xylose. Other tests that are sometimes used are measurement of a stool pH. Most sugars cause the stool pH to become slightly acidic and less than 6. There's another test called the Clini test, which detects undigested sugars. This is best used in children who have less sugar absorption in the colon, so sugars that are not absorbed in their small intestine may pass all the way out into the stool and register as a positive Clini test. Abnormal findings on either of these tests suggest carbohydrate malabsorption. They're both abnormal in the setting of lactose intolerance for any reason. Both of them are rarely used in modern settings, but you will see them sometimes used in resource-poor settings because they're cheap and easy to administer. And that concludes our module on malabsorption.